Hello, everybody. Welcome back to the Incubator Podcast. We're back today for an episode of Journal Club. Daphna, how are you?
I'm doing well. We had some articles that were left over from last time because you had such big hitters last time,
Yeah, it's been
discussing the PDA and whatnot.
yeah. That article definitely made the rounds. There's been a
Hmm.
lot of discussion about it. Um, but like we said last time, it's nice to have these sort of goalposts of saying like, this is where we're going to plant the flag for now, and
Yeah,
then let's see if we can move it.
for
So
sure.
yeah, and it's been a busy, I think for us, especially from the editorial standpoint, it's busy on the article front
Yeah,
when there are such major reports coming out, because we also like, as you've seen on the podcast, to review some just smaller studies sometimes, but have very interesting questions or
yeah,
some very interesting findings.
for
And
sure.
unfortunately, obviously, these have to take a little bit of a backseat when the AP comes out with a report on the PDA. That sort of has to take a backseat. And so our our list has been piling up. So there's definitely a lot of articles to review, and very excited about today. There's a lot of very interesting topics that we're going to touch on. So if without much further ado, we're going to get started. I just wanted to give two quick updates to the audience. Obviously, we are processing the submissions for the annual giveaway. So if you haven't heard anything from us, it's not like we will respond to everybody, but we're actually just tallying all the entries and so on and so forth. We are a notoriously inefficient group. So
Well, I think we prioritize journal club and board review and
yeah, yeah.
interviews,
Oh,
but
I'm
we'll
not.
get
Yeah,
there. We'll get there.
we'll get there. But I'm saying it's our fault. It's not. It's
Yeah,
not nobody's
that's
else's
right.
fault. And then obviously the Delphi conference is open for registration, and we're going to have more content coming your way about the speakers and the lineup. It's going to be very exciting. You're not going to want to miss this. Again, we're keeping this a very intimate type of
Yeah.
conference. We are not going to have unlimited amount of spots. It's a limited seating. So if you plan on attending January 26th to 28th, 2026, you're coming to sunny Florida in the middle of winter. It's always going to be pleasant. And we have never invested as much time and effort in the
Hmm.
lineup and in the curation of the content. So it will be quite exceptional.
And
That
people
being
are already registering, so that's exciting.
Oh yeah, yeah, no, and that's why I wanted to remind people. I don't want people to get into a position of like, oh, I wanted to register and was too late, like that. But there's really nothing we can do. We pick venues that
Yeah,
have a certain number of seats. Like it's
right.
not like we're not being assholes and saying, oh, you can't come in. It's like there's a certain number of seats.
Yeah.
After that, we can't because no, like it's not whatever.
Yeah, and
All
I
right.
think it's good for people to know also as they are making their planning. We have a hotel selected, the Flow Hotel, which is very South Florida, but very comfortable.
Oh yeah.
Even options for like people who want to like share rooms and stuff, want to travel together.
These are like
So
mini apartments.
yeah, for sure. So we want to
Very
make sure
nice.
that everybody's really comfortable, that there's a lot of flexibility. If you want to come with a group or you want to bring your family,
Yeah,
that
so
we
just
can
people
accommodate
so
that.
people know, like when we say that, like these rooms are very sort of a lot of wood, like very
Yeah.
relaxing, very nice views,
Yeah.
and they're kind of little apartments, so you actually have some independence. There's a very nice gym. There's a very nice pool. There's some outdoors yoga area. Like when we say that it's going to be a relaxing conference where people will leave with more energy than they left with, that they came in with, then we truly mean that, and we pay a lot of attention to make that happen. So, all right, let's get going with the journal club. The first paper I wanted to review, Daphna, is a very interesting one that I saw in JAMA Peds. It's called Severe Neonatal Morbidity and Cause-Specific Mortality Through Infancy and Late Adolescence. First author is Hilary Graham. It's a study that is coming to us out of Sweden, that examines the long-term mortality implications of severe neonatal morbidity. I think this is particularly relevant as we see more infants surviving the neonatal period, but potentially with significant health challenges. Now, while neonatal survival rates have dramatically improved, we're seeing more infants surviving the neonatal period, but experiencing morbidities that we know may have lasting consequences. And what the authors point out is that identifying key morbidities during the perinatal and the neonatal period could help us target those at greatest risk for early life mortality. I think it's something that we cannot shy away from, but it's terrifying to talk about early life mortality for children. So in the paper, they talk about this concept of SNM, severe neonatal morbidity, that they say during the first 27 postnatal days, has been identified as an important health indicator, though it encompasses a variety of diagnoses and is often defined inconsistently across studies. Now, common severe neonatal morbidity diagnoses include IVH. They include extremely and very preterm birth. They include sepsis, all associated with an increased risk of morbidity and mortality. Now, previous research on this topic has shown striking findings that I think we're all kind of aware of, but when we actually look at the data, it's definitely not something that we talk a lot about. One study actually had demonstrated that infants with certain neonatal morbidities have a tenfold higher risk of death in their first year. Another one found that SNM, severe neonatal morbidities, and I'm going to start using that interchangeably, is a strong risk factor for infant and child mortality up to 5 years of age, and is significantly associated with higher mortality from conditions affecting the endocrine, the nervous, the respiratory, and the circulatory system. Now, what their authors are mentioning is that longer term follow up for specific SNMs subtypes and overall SNM beyond 5 years of age has been lacking, with little known about cause-specific mortality in that population. There's also no studies that has looked at sibling control analyses. So this group out of Sweden basically decided to examine the association between SNM during the neonatal period and all cause and cause-specific mortality from infancy to adolescence using both population-based and sibling-controlled analysis. So the Swedish group here in this paper basically did a population-based study from 2002 to 2021. This is taking place in Sweden, and it's leveraging a lot of the database that they have over there using the Sweden's comprehensive registry system, cross-linking the medical birth register with the Swedish neonatal quality register, the national patient register, and the cause of death register via unique sort of this national identification number. Now, basically, the National Patient Register contains information on all inpatient diagnostic codes and procedures since 1987, which is kind of incredible, and outpatient care from 2001. And the cause of death register captures about 99% of all death in Sweden since 1952. So quite incredible. Um, this basically allowed them to look at a final study population of about 2 million singleton neonates. Now, the main exposure that they're looking at was the occurrence of severe neonatal morbidity among all live-born neonates identified from birth through 27 days. SNM was defined as a composite event consisting of 5 distinct categories with 19 specific subtypes. So they had respiratory morbidity, which included RDS, congenital pneumonia, BPD, other respiratory disorders, pneumothorax requiring drainage. They had a second category for SNM infections encompassing sepsis and bacterial meningitis. Then they had neurological morbidities, included IVH, grade 3 to 4, hypoxic ischemic encephalopathy, seizures, cerebral infarction, PVL, and neonatal hydrocephalus. They had specific respiratory procedures, including resuscitation requiring intubation and mechanical ventilation. And then they had a sort of catch-all category called other, including neck, intestinal perforation, ROP, and birth trauma. So the researchers extracted all-cause mortality, primary underlying cause of death from the registry, and they categorized them based on different timelines. So you had death between 28 days and 11 months. That was called infancy. Then they had childhood deaths, 1 to 4 years of age, later childhood, 5 to 9 years old, adolescence, 10 years and beyond. They looked at covariates that included neonatal characteristics such as gestational age, birth weight, sex, being small for gestational age, 5-minute Apgar score, birth year, and any major malformation. Now, what was very interesting was that in order to investigate potential confounding from shared family-related factors, they wanted to find out, like, what could these potential outcomes, mortality, terrible as it may be, could it be related to some familial component? Like maybe they have something genetic. And so they conducted a sibling-controlled analysis, sibling pairs discordant on their prevalence of SNM, Again, SNM standing for I always have severe neonatal morbidity, exposure were included with the model adjusted for infant factors and maternal factors, including maternal age, parity, smoking status, cohabitation status, educational level, pregestational diabetes, BMI, pregestational hypertension, and smoking status. So I was very interested in that particular aspect also of that secondary analysis. So let's dive into the results because I think they are very interesting. As we mentioned, of the 2 million live-born singleton infants included in the study, 49,225, that is 2.4%, had a diagnosis related to severe neonatal morbidity within the first 27 postnatal days. Infants with SNM were more likely to be preterm, they were more likely to be male, they were more likely to be small for gestational age, they were more likely to have a lower 5-minute ABGAR scores, and they were more likely to have major malformations compared to those without severe neonatal morbidity. Severe neonatal morbidity prevalence was also higher in infants of mothers who were young, 19 years or younger, nulliparous, less educated, living alone, smoking, um, or who had an elevated BMI or who had pregestational diabetes or hypertension. Now, during a follow-up period ranging from 28 days to up to 21.2 years, 3,618 children died with an overall mortality rate of 0.16 per 1,000 person years. Now, here's the critical finding. Children with severe neonatal morbidity had a dramatically higher mortality rate of 1.81 per 1,000 person years compared to 0.13 for those without any morbidity. Now, in adjusted models over the entire follow-up duration, children with severe neonatal morbidity had a 5.92-fold higher, I'm sorry, I'm butchering this, but almost a 6-fold higher adjusted hazard ratio of mortality compared to children without severe neonatal morbidity. Mortality rates were elevated for all types of morbidities, but some were particularly severe. So compared with children who didn't have any severe neonatal morbidity, the adjusted hazard ratio for mortality were over 10-fold higher among infants with other respiratory disorders, meningitis, severe IVH, HIE, seizures, cerebral infarction, PVL, hydrocephalus, neck, SIP, and mechanical ventilation. Neonatal neurological conditions were the leading morbidity associated with a almost 18-fold increase in all-cause mortality after 28 days of life. I mean, these are staggering numbers. And the study revealed significant sex differences as well in cumulative hazard estimates for all-cause mortality. And what was very interesting was that we tend to think that, rightfully so, that survival rates for female infants in the NICU is usually higher than male. But total mortality in that cohort was higher in female children compared with male children. The adjusted hazard ratio for all-cause mortality were 7.28 in female children compared to about 5 in male children. In particular, the association between severe neonatal morbidity and neurological morbidity was stronger in female children compared to male children. So, stratified analysis by gestational age indicated that among those who had a severe neonatal morbidity, the mortality rate was higher in children that were born preterm compared to those born term, and that is probably expected. However, compared to those without severe neonatal morbidity, the association between morbidity and mortality was stronger in term infants with an adjusted hazard ratio of 7.16 compared to preterm infants with an adjusted hazard ratio of 3.51, highlighting the fact that when term infants run into problem, it can have even more dramatic consequences than sometimes in other in preterm infants. The study demonstrated that severe neonatal morbidity was associated with higher mortality after 28 days of birth, with associations persisting for several years, but weakening over time. So compared to a cohort that had no morbidity, babies who had some severe neonatal morbidity was associated with adjusted hazard ratio of 7.66 at 28 days to 11 months, 5.2 from 1 to 4 years, 4.98, 5 to 9 years, and 2.28 at 10 years or beyond, as you can see, sort of tapering over time. Importantly, infants with neurological or respiratory procedures had elevated mortality risks even after 10 years compared to those without severe neonatal morbidity. So I'm going to wrap up by talking about the sibling analysis that we alluded to earlier on. They included 32,000 children with morbidities versus their full siblings without any morbidity, and revealed similar association as in the population analysis. The sibling analysis showed an adjusted hazard ratio of 4.33 compared to the overall population result of 5.92. And so among the SNM subtypes in the sibling analysis, all associations except respiratory distress syndrome and BPD were similar to those in the primary analysis, though with some attenuation of estimated hazard ratio and or precision, which is so interesting because it looks like there might be some genetic component to the respiratory pathology and maybe the extent, right? I mean, if a family has, I'm giving an example that they didn't speak about that. This is me going on a limb here, but like a family of severe asthmatics, that may put a baby that then has some type of morbidity in the NICU at an even higher risk of mortality down the road compared to someone who's born in a family of quote unquote perfectly healthy lungs kind of situation. So I thought that was kind of interesting, even though the data is kind of limited. So in conclusion, the author is saying that the cohort demonstrates that infants with severe neonatal morbidities who survive the neonatal period experience increased risk of mortality into childhood, but also in adolescence. Neurological morbidities and respiratory procedures are the major contributors to both short-term and long-term mortality. And efforts to further prevent severe neonatal morbidity, ensure early identification, provide long-term follow-up, I think that's the key, may help reduce mortality and inform discussions with families regarding prognosis and follow-up needs. Daphna, what are your thoughts? It's the kind of data I would be terrified to present to families in the NICU.
Yeah. Well, I mean, I think it's not unexpected information, but I think it's really important when we talk about long-term outcomes. It's kind of this like cumulative effect, you know? It's not just gestational age, it's not just birth weight. And I sometimes feel like we have this sense, especially for people who aren't doing follow-up, wow, like we got this very sick baby to the end post. They're going home, and that's great. That's wonderful. I mean, we are making extraordinary strides on getting babies to discharge. Um, but that cumulative effect of these morbidities and the impact on long-term mortality is impressive.
Mm-hmm.
And I think we need to keep that in mind, and we have to keep working on how do we safely transition these babies home and what types of resources do they have. I mean, you and I both know in our area, for example, these medically complex kids, I mean, home nursing is a disaster, you know? So we really have to figure out how to optimize those things. And I was especially like you interested in the sibling data. You know, we've got a special event for Delphi specifically for multiples, and so it was interesting to see that as well.
Mm-hmm. Yeah. Yeah, I think that, like you said, when you compound everything, Sweden has a very robust sort of social healthcare system. So when you compound the fact that how difficult it is, at least I'm talking for ourselves, for parents to actually go to these multiple appointments, to get access to the different subspecialists with insurance issues lapsing and so on and so forth, it definitely probably means that odds are probably higher in a setting like ours. Again, this is a very Again, this is Sweden, which is one of the leading countries when it comes to neonatal care. So we're not talking about
Yeah.
really a underserved sort of
Right.
really emerging field of neonatology. These are the guys who actually know what they're doing. This is these are the Scandinavian teams that we inspire ourselves to strive for. And so
Yeah,
it's
and the social networks there are quite robust, right?
yeah, yeah, yeah,
You know,
no, for sure.
parental leave and
I
universal
mean, I
health
wouldn't
care
even know
and
the state of our situation here in the US would be like, how would we even capture the data? Like, I
yeah,
mean, just like, would we able to capture the data? How many times do you hear of a baby who has somehow appeared at an outlying ER that may not be affiliated with your healthcare
great.
system? And it's like, oh my God. So anyway, very interesting
Neat.
data. Yeah, very interesting data. All right, where
All
are you
right.
taking
Well,
us next?
I had this paper that we can hopefully we can reduce some of these morbidities. It's an active pediatrica. It's entitled "Prone Positioning was associated with less hypoxemic events and improved feeding tolerance in preterm infants." Lead author Bettina Bonhorst, senior author Carolyn Bone. This is coming out of Germany. And so basically, what they wanted to look at was how did positioning affect cardiorespiratory events? So apnea, bradycardia, and hypoxemia. hypoxemia, that's the right word, which we know are very common in preterm infants. And we are learning that the frequency and especially the severity of hypoxemic events are impacting neurodevelopmental outcomes. So, um, it's a small study. I will start by saying that. But between May 2016 and July 2018, they did a single center prospective randomized two-arm crossover study at Hanover Medical School, their tertiary NICU, and they enrolled preterm infants with gestational age of less than 32 weeks at birth and less than 34 weeks at postmenstrual age at the time of the study. And the babies had to be having some of these clinical events. So, more than 6 episodes of hypoxemia, less than 80%, and bradycardia less than 80 beats per minute in 6 hours. That's not a small amount of events. It's quite a large number of events. They excluded babies with congenital malformations, intestinal pathology, or babies, they write here, need for non-invasive positive pressure ventilation. So these are babies on like NIMV, or babies on mechanical ventilation. So all of these babies were extubated, and in terms of breathing support, then they were on room air, they were receiving supplemental oxygen, or they were getting high flow nasal cannula or CPAP. Um, and importantly, the ventilatory support did not change for any particular baby over their study period, though some babies may have needed intermittent adjustment if they had a prolonged event. So basically, the patients were then randomly assigned using random number generator to either group A, which was prone, or group B, which was supine as their starting position. And each patient spent 12 hours documenting events in their starting position. They had a 12-hour washout period, and then they switched positions between the two recordings. So then they looked at all of the events for these babies. So for baseline data, again, I told you they had 48 patients. The median gestational age was 26.9 weeks, with a range of 24.4 to 30.3 weeks gestational age, and a mean birth weight of 884 grams, plus or minus standard deviation of 250 grams. And at the study, patients had a mean postmenstrual age of 31.7 weeks and a current weight of 1,273 grams. So each group had 24 patients. The demographics were pretty well matched, in particular for gestational age, but I will highlight that the median weight at study entry was significantly lower in group B, which was the prone group. A median weight at enrollment of 1,163 grams compared to Group A, 1,378 grams. And I think that's important because remember, we're comparing. So Group A is prone, Group B supine, but the Group A babies, the prone group, had a a higher median birth weight. Okay. The total number of hypoxemia and bradycardia events did not appear affected by the starting position. And there were no carryover effects in any of the secondary outcomes. So the primary outcome they were looking for was a cumulative frequency of hypoxemia and bradycardias per hour. And they found that this was significantly decreased and almost halved in the prone position compared to the supine position. So the median frequency supine was about 17.6 compared to prone 8.3. And this decrease was primarily a result of an almost halving total number of all hypoxemias in the prone position. So the prone position uh, ch- impacted both moderate, so SATs of kind of 85 to 80%, and severe, so SATs less than 80%. So they showed an improvement in both types of hypoxemias. The occurrence of bradycardias did not differ between the two positions, so that was not statistically significant when they looked at those findings individually. They also had a number of secondary endpoints. So they looked at the total time spent in hypoxemia. This was significantly decreased and more than halved in the prone position. So the cumulative duration supine was about 37.5 minutes compared to prone, which was 16.3 minutes. And this was particularly relevant for those, again, severe hypoxemia is less than 80%. The supine group spent about 22.9 minutes compared to the prone group, 9.1 minutes. They showed a trend toward a worsening of severity of hypoxemias in the supine position by about 6%, but this was not statistically significant. They also wanted to look at the median duration per event. This did not appear to be statistically significant either. Basal parameters for all the patients. So they wanted to look in particularly at that quiet sleep. So median heart rate, respiratory rate, occurrence of periodic breathing, or the need for supplemental oxygen delivery did not differ significantly between prone and supine positions. But they looked at the median and the minimal baseline SpO2. These were significantly increased in the prone positioning. So, whereas the median saturation for supine was about 96.3%, in the prone position was about 97.9%. And then the minimum saturation, the average minimum saturation in the supine position was 92.9%, and the prone position, 95.1%. I told you early on they were all also looking at how this might impact feeding. So they looked at gastric residuals from the previous meal. And, we're moving away from checking gastric residuals, but this was interesting. The gastric residuals from the previous meal was significantly lower in the prone than in the supine position, though they were hoping to reach a 20% threshold. But the median remaining gastric residuals in the supine was about 3.75% of the previous meal, compared to the prone where some babies had nothing left. So that was the median gastric residual. And then they looked at the maximum gastric residuals. And this was also statistically significant. In the supine, it was about 12% of the previous meal. In the prone, it was about half of that, 6% of the previous meal. So I told you a lot of good things about the prone positioning, but interestingly, the frequency of apneas was increased in the prone position compared to the supine position. So median number per hours in the prone was 1.2. Um, and the supine was about zero point 0.4, and this was statistically significant. So the median duration per event did not differ between both positions. So again, I want to highlight that it looked like the prone positioning did offer quite a number of benefits, but this was in a group of babies that were slightly bigger. And we know that's an important factor for outcomes in the NICU, especially in this early population. But I think it's interesting. I think there are still units that aren't using prone positioning like at all. I was kind of surprised to know that. And so I thought this was a useful paper. Thoughts?
Yeah, I mean, it's always interesting when you have a small study like this that is able to reach a statistical significant result. It means that the difference that they were able to achieve is staggering, and I think that this is something that should be looked at. Again, as you mentioned, they have a small number of patients, and
Mm-hmm.
that's okay. But they're able to decrease the number
Yeah.
of
By
events
50%.
by 50%. That is not benign. Now, granted, I think that this is data that continues to corroborate what we know about prone positioning, and it doesn't obfuscate the issue of prone positioning, which is we can't leave these babies prone 24 hours
All the
7.
time. That's right.
But it is an intervention that is at your disposal. Use it judiciously.
Yeah. It's interesting too about this gastric residuals. I mean, could that help with some of our reflux type problems? I don't know. I mean, they didn't prove that,
You even check
but it's
residual,
interesting.
bro?
Yeah, that's right. We don't check residuals. But I thought that was interesting.
Yeah, very interesting indeed. Okay. Um, All right. The next paper I have for you, hydrocortisone and the risk of sepsis in neonates born extremely preterm. First author is Olivier Beau, who is on behalf of the Premiloc study group. I had the pleasure of interviewing Olivier with Gabriel Altit on the French edition of the podcast. If you are French speaking, go listen to it. He is a brilliant mind and who has done a lot of work with Christy Waterberg on the use of hydrocortisone. Christy mentioned him repeatedly during our interview with her on the English edition of the podcast. So, what the team at the Premiloc study group wants to look at is examining basically a critical safety concern surrounding the use of prophylactic hydrocortisone in extremely preterm infants. Now, this is basically a post hoc analysis of the Premiloc trial that addresses one of the main barriers of implementing prophylactic hydrocortisone as standard of care, because despite the evidence that has been published on hydrocortisone and because of the long-term outcomes associated with the use of hydrocortisone, it's not really been sort of favored as the standard of care. So now the group mentions obviously that the increased susceptibility to infection in preterm infant is primarily due to a deficient immune system, an immature epithelial barrier, increased need for invasive devices, and that extremely low gestational age neonate population, or LGAN as they are known, is at a particularly high risk for late onset sepsis, with approximately 20% of neonates experiencing at least one culture proven episode prior to discharge, according to certain data. Now, prophylactic administration of low dose hydrocortisone in that population has been shown to improve survival without BPD and to reduce the need for treatment of PDA and reduce pre-discharge mortality. As a result, it's increasingly being introduced as a standard treatment in certain NICUs. I know that Olivier and some of his colleagues adamantly believe in the use of prophylactic hydrocortisone for this very vulnerable population. But they are being honest in the background section, mentioning that some systematic reviews support the benefit from early hydrocortisone treatment, particularly in infants with a gestational age at birth above 25 weeks. There's concerns regarding safety. And although some neonatal centers have incorporated the Premiloc regimen into local practice, prophylactic hydrocortisone is not currently recommended as standard of care. Now, the major safety concern that is being brought about is from an individual patient data meta-analysis of the main trials using prophylactic hydrocortisone to prevent BPD or neonatal death, which showed an increase in risk of late onset sepsis, with an odds ratio of about 1.34, particularly in a subgroup of infants born between 24 and 25 weeks of gestation, where the odds ratio is 1.87. Now, the adverse event is undoubtedly a barrier to further implementation of this prophylactic strategy. Surprisingly, they say this potential adverse event did not result in additional risk for neonatal mortality, mortality at discharge, or neurodevelopmental disorder at 2 or 5 years of age. Real-world data have come from single-center retrospective cohorts in the UK, in Canada, in the US, and more recently, Sweden. So the purpose of the study is to reanalyze the Premiloc dataset to predict late-onset sepsis incidence from baseline conditions and examine perinatal factors influencing the incidence of late-onset sepsis and assess the potential interaction arising from prophylactic hydrocortisone exposure. So, like we said, post-hoc analysis of the Premiloc trials, which was double-masked, placebo-controlled, multi-center, randomized trial that basically enrolled extremely preterm infants delivered before 28 weeks of gestation from 21 perinatal centers in France. Eligible infants were randomly assigned to receive either prophylactic, low-dose hydrocortisone or placebo, starting within 24 hours after birth and for a total duration of 10 days. The primary endpoint of the original Premiloc trial was a composite endpoint defined as survival without BPD at 36 weeks of post-menstrual age. Now, the primary outcome of our paper today of this post-hoc study is the risk of late onset sepsis defined by a positive blood culture or a diagnosis of pneumonia with significant clinical deterioration detected after day 3, according to the international definition of late onset sepsis. Pneumonia specifically was defined as a chest x-ray showing pulmonary opacities associated with the presence of a positive culture in the airway and clinical deterioration after day of life 3. Late onset sepsis occurring after day 7 or day 10, that is at the end of the hydrocortisone exposure, was considered as an endpoint for the sensitivity analysis only. Now, the researchers categorized respiratory support at baseline into 3 categories. You had respiratory support at baseline RSB that was considered mild if you were on non-invasive ventilation with less than 30% FiO2. You were moderate if you were on mechanical ventilation with an FiO2 less than 30%, or severe if you were on mechanical ventilation with a need of 30% or greater. Secondary neonatal outcomes specifically included the total number of days the infant was mechanically ventilated, age at weaning from respiratory support, PDA, and treatment for PDA, medical or surgical. So in terms of the data, they were able to basically get most of the babies from the Premiloc cohort. So out of the 523, they were able to do that analysis on 519 of them based on like some consents that were pulled, but nothing really crazy from that standpoint. A relative difference of more than 15% between the compared group was found for general anesthesia and general hypertension and gestational hypertension only, and there were no other significant differences between other variables in the baseline characteristics between the babies who did receive hydrocortisone versus the ones who did not. So let's get into some of the outcomes. Overall, the proportion of late onset sepsis reported in the population was 27.2% after day 3, 23% after day 7, 17% after day 10, with a significantly higher proportion in the hydrocortisone treatment group. The case fatality rate likely attributable to late onset sepsis was 23% in the placebo group and 26% in the hydrocortisone group. Now, using a stepwise strategy to study the occurrence of late onset sepsis occurring after day 3, the main analysis provided basically 3 main predictors at baseline for an increased incidence of late onset sepsis. A decreased risk of late onset sepsis was observed with increased gestational age, with a relative risk of 0.772 per week. Vaginal delivery was also associated with a decreased risk, with a relative risk of 0.611, and perinatal asphyxia, which showed a trend toward increased risk with a relative risk of 1.66. Among covariates occurring during the first postnatal week, supplemental steroids given after 10 days of treatment with prophylactic hydrocortisone, but before any form of sepsis occurred, were found to be associated with a decreased risk of LOS. So the supplemental use of hydrocortisone somehow lowered the kids who did get supplemental hydrocortisone had lower risk of developing sepsis. For the effect of hydrocortisone treatment on the risk of late onset sepsis, the model predicting the occurrence of sepsis found in the previous section, these 3 variables, that when it was used, the hydrocortisone effect in adjusting the risk of sepsis for gestational age, vaginal delivery, perinatal asphyxia, and even supplementary corticosteroids, the proportion of late onset sepsis was 24.5%, with a standard deviation of 9.8% across the centers, giving a variation coefficient of 0.33. The effect of the 3 main adjustment variable did not change, and adjusted for these covariates, the researchers found a non-significant hydrocortisone effect with a relative risk of 1.04. When they investigated late onset sepsis occurring between day 3 and the end of the course, day 10, and adjusted the same model, they find that treatment effect with a relative risk of 0.96, so almost no difference. The researchers also performed a competing survival analysis, which was very interesting, using the Fine and Gray model, considering death and late onset sepsis as competing endpoints. And after adjustment for the baseline variables associated with the risk of late onset sepsis, again, gestational age, delivery mode, perinatal asphyxia, the effect of prophylactic hydrocortisone on late onset sepsis was found not to be statistically significant, while competing death was reduced by the treatment with a hazard ratio of 0.427. And so the conclusion of this tedious data analysis is that, considering basically baseline risk factors, the risk of LOS, of late onset sepsis, is not significantly different between the group that receives prophylactic hydrocortisone and placebo. And this competing survival by Fine and Gray analysis suggests that death was reduced by the prophylactic use of hydrocortisone without a significant effect of the treatment on the risk of late onset sepsis. These results obviously should be confirmed, they say, in larger real world population-based cohort studies. And I think that, to me, it's very interesting because, again, it's Olivier just really standing behind the data and standing behind the Premiloc trial. And to me, I don't know how I take this data at face value, but I think the underlying message is the right one, in my opinion. Every baby is not the same. There are baseline risk factors that will make a baby more likely to benefit from this treatment versus others, whether it is exactly the gestational age, which again we kind of know, but vaginal delivery, whether it is perinatal asphyxia, and so on and so forth. Um, those are very interesting to investigate, and I think that maybe it is a way of the Premilock team to sort of move away maybe from a more wholesale prophylactic use of hydrocortisone, and they'd be saying maybe there is a subpopulation that would truly benefit the most and benefit the most from the benefits of hydrocortisone, all the while not being exposed to potentially some of the adverse effects that we have been concerned about. So I think this is very interesting, and that's why I wanted to review it.
Well, and I think, I mean, it's always complicated when you are like interrogating data, right? That wasn't intended for that purpose. But I mean, when you have studies with such large data sets, I almost feel like you're obligated to do some of this additional work because, you everybody's done the work. The patients have been enrolled. The information is there, and so we should be looking at those, if nothing, to just generate new, hypotheses and go from there. But I do think this is relevant, right? People are worried that if we give steroids very early at a baby who may be at risk for infection, will we compromise the immune system and they'll be more likely to be infected. So I mean, I do think this targets some concern people have about early hydrocortisone. And I think one of the groups that we think are most likely to benefit are those babies with a history of chorioamnionitis. So I think this is especially interesting as well.
Yeah, and I just want to mention basically, I mean, obviously, I invite everybody who hasn't read the Premilock trial that was,
Mhm.
what was it? It was published in the Lancet, I believe.
Yeah,
Um,
2016.
16, yeah. I think that in the Premilock study, what was interesting, obviously, is the fact that in that particular population, when they reported the severe adverse events, they didn't see any difference in the change in the adverse event, except for the fact that babies who received hydrocortisone had a lower mortality rate prior to discharge. And when it comes to sepsis, the numbers were fairly the same. They had about a 31% rate of late onset sepsis in the hydrocortisone group and 25% in the placebo group. Um, and it's I think you were saying they're interrogating their data, but I feel like also there's that sense of, well, these other meta-analyses are doing that, right? And these individual patient meta-analyses. So I think this comes as a response potentially to that. And but it is tedious work for sure. And what you do with that information, I don't know. I'm curious to see what the response on Twitter is going to be to this because
That's right.
hydrocortisone divides more than anything in our field.
And for people who want to listen to our interview with Dr. Waterberg, it was episode 53. She took a chance on us when we were still pretty early coming to chat with us on the podcast in that first year. So people can take a look at that.
That was a big
Um,
get.
yes, we were starstruck, as it were. um, I had another interesting paper. It's actually in the journal Nutrients, and it's entitled "From Warm to Cold: Feeding Cold Milk to Preterm Infants with Uncoordinated Oral Feeding Patterns."
Whoa.
Senior author Nazi Hannah, and this was done in New York, collaboration between NEOs at NYU and the University of Arkansas. So basically what were they were the background is kind of interesting. So they recognize that in adults with dysphagia, cold liquids enhance swallowing by stimulating these sensory receptors in the pharyngeal mucosa. So they had previously shown that feeding infants with cold liquid had reduced dysphagia in preterm infants. But I think a lot of units are still not using cold feeding, so that's something that they wanted to look at. Um, so basically, they selected these infants that had kind of this concern for disorganized feeding, and then wanted to compare cold milk or not even warm milk, room temperature milk. So I thought that was really interesting. I will go ahead and give you the punchline early that the predominant results of the study are negative. But I think that's interesting in and of itself because, we spend a lot of time warming milk. So I thought that was interesting. But I'll give you some of the details. So they enrolled preterm infants less than 37 weeks gestational age of birth with a postmenstrual age of 34 to 42 weeks. So they were targeting these babies who were working on PO feeding at the time of enrollment, and they had to have a documented uncoordinated feeding pattern using the infant driven feeding scales, or the IDFS, which they were routinely using in their unit. Infants were excluded if they had a growth restriction, history of GI pathology like neck, gastroschisis, malabsorption, diarrhea, or omphalocele. They also excluded babies with NAS because of its potential effect on feeding behavior. So each participant then was exposed to 2 oral feeding conditions. So either room temperature, which was 68 to 77 degrees Fahrenheit, or cold temperature, 39 to 48 degrees Fahrenheit, in a randomized crossover design. So babies were started with one. They had this washout with a number of feeds, but within a 12-hour period, they were given the other feeding regimen, the other temperature. Um, so that way they had enough time to warm back up if it was cold, but to reduce, much change in clinical status. So in the room temperature, the control condition, infants got their kind of usual milk, either formula or breast milk, at room temperature. And then again, the cold condition, it was never brought to room temperature. Feeding was performed by a trained research member, with infants positioned in this side-lying posture using a slow flow nipple. Um, they studied the babies. They wanted to look for other signs of cold stress. So they looked at axillary temperatures. And any baby who already had an ENG tube in, they measured the temperature of the gastric contents. They didn't put NG tubes in babies who didn't have them, um, because they thought this was like an unnecessary kind of trauma. They measured the temperature of the gastral aspirate, as the baseline in room temperature, and then the cold temperature, they looked at it at 1, 10, and 30 minutes post-feeding, to look at return to baseline. They looked at other clinical signs of cold stress, so tachypnea, desaturation, apnea, bradycardia, increased gastric residuals, and emesis. They also used Doppler ultrasound, not in the whole cohort. This was a small study, but an even smaller subset of the patients. They looked at Doppler ultrasound to look at superior mesenteric artery blood flow as a marker of intestinal perfusion, especially given concerns about feeding cold milk potentially. And for the Doppler assessments, they any baby who was studied by Doppler um, had a kind of a 1 hour before feeding baseline, and then 30 and 60 minutes after each feeding. Okay. They, in terms of the feeding performance assessment, they used a number of parameters, and they kind of evaluated them at 5-minute intervals. They used the oral feeding skills score, and they used, like I told you, the infant-driven feeding scale. They also used 2 additional subjective measures, so stress cues and the need for pacing, um, using the stress scale and the pacing scale. So they're subjective, but there are scales to evaluate that. And I told you they were looking for other cardiorespiratory events. So, a small study, 26 preterm infants, and they had 5 infants who underwent the Doppler assessments to evaluate mesenteric blood flow. Median gestational age at birth was 31 weeks and 6 days. The median day of life at enrollment was 28 days, with a median postmenstrual age of 36 weeks and 1 days. All of the babies had previously done some oral feeding, with a median of 8 days of partial oral feeding before enrollment. So 14 infants started with room temperature, 12 infants started with the cold temperature, and again, it was a crossover design. So there was no significant reduction in axillary body temperature. The gastric temperature measurements again were only performed in babies who already had an NG tube. So this only included 7 babies, and by 1 minute after feeding, the temperature of the cold milk had increased from what it was fed at, 39 to 48, to an average of 83.3, basically upon reaching the stomach, so within 1 minute. The gastric content temperature following the cold feeding was only 3.6 degrees lower than that observed after room temperature feeding at the 1 minute time point, and this was statistically significant. In terms of all those other signs of cold stress, babies didn't have any difference between the two groups. Again, in the small group of babies who had a superior mesenteric blood flow measurements, there were no significant differences between feeding types. And then feeding assessment. So there was no statistically significant difference in the OFS scale levels between the two feeding conditions and other objective measures. So proficiency, so looking at the volume, percent of volume ordered, the rate of transfer, and the overall volume did not differ significantly. Subjective assessments of stress cues and the need for pacing showed no significant difference. However, they did find one difference. So, coordination of sucking, swallowing, and breathing is measured by the infant dysphagia feeding scale, demonstrated a statistically significant improvement with the cold temperature as compared to the room temperature. And the mean IDFS quality score was 3.2 with room temperature and 2.6 during the cold temperature condition. So basically, better coordination during the cold temperature feeding. I had it pulled up here. Sorry, the infant dysphagia scale for people who are not familiar with it. Oh, let's see if I can find it for you.
You
But
can
I mean, basically, um,
I'll find it.
yeah, you find it. I just wanted people to know like what the scale numerical values are. But this was a kind of a reasonable improvement. They wanted to look at like what is the clinical relevance. So they looked at the babies individually. So 10 out of the 21 infants showed between a 1 to a 3 point improvement. 10 showed no change, and only one infant had a 1 point decline when being fed the cold milk. Um, uh, Compared to the room temperature milk. So some of the feeding parameters didn't change, but I think their hypothesis was that it would impact dysphagia, and they did show a statistically significant improvement in that. So again, a small study, but I think they did a really good job at looking at some of those balancing measures that I think people are worried about.
Mhm.
And so many of our babies are staying for a long time just for feeding readiness. And so it's interesting to look at what other ways can we modify feeding to potentially improve feeding outcomes. So
I couldn't find I'm afraid I'm gonna
yeah,
pull up
sorry.
a
I
table
know.
that is not the right one, but it's a very interesting. I mean, I think you shot our enthusiasm a little bit in the beginning by giving the punchline, and I think that maybe a lot of nurses who are listening, who are looking like, "Oh my god, I'm not gonna have to thaw the milk as much as the before, save a lot of time." But it's an interesting approach, and I think that, especially for the room temperature milk, what do you think based on the data? Obviously, this is a relatively small study, but the question is this something you would try? Like, let's say a baby is stuck a little bit, is learning to like, would you say, hey, try room temperature and see if that makes any difference?
Well, it's interesting because in our unit, we don't even use room temperature milk. I mean, it's slightly warmer than room temperature. But I think so, especially a baby who is at that point. We have babies that are full term that are still struggling to feed, and plenty of babies who are full term at home are getting cold. cold milk.
Mhm.
So yeah, I think in a baby where we're really stuck, maybe there are some babies that would benefit from this.
Would
So
you try
yeah,
cold?
I think
Yeah,
so.
because I
Yeah,
think I think that's the other thing that I sort of didn't mention. But yeah, I mean, we all probably, I would think we're all using similar machines and stuff.
yeah,
So it's our milk is probably on the warmer side than on the colder side. And I feel
yeah.
like as a human, we may want to feed a warm bottle of
It
milk
feels
to a
like we
bit.
should, right?
It feels like we should exactly. But I'm
Yeah.
just curious if you might say, all right, like let's try a cold bottle.
Yeah, I think if you're really stuck, especially in a baby, again, they were using these kind of late preterms, but I mean, they were premature babies who are now at feeding age. I think people are still always concerned about this cold stress or mesenteric, ischemia. I don't think they had enough numbers to really look at that, but
I mean, it's a chilled glass of milk. I mean, it's like 5 to 10 degrees centigrade.
which as an adult is delightful. Okay, nobody wants warm milk once you hit a certain age. So I think I would try it,
Interesting.
especially I think in a baby who's stuck at term corrected, and
Yeah,
see.
especially when you have, I mean, these are the interesting interventions where you don't really need a lot of data to
Right.
safely just try, like, just like
Yeah.
when we talk about all these interventions regarding like music in the NICU, it's like how much data do you need to put like a very soft lullaby to the babies? I think it's interesting. All right, I'll look out for the babies you try this on and see if they're working already then.
We've all been there, right? At my own home, somebody had pumped milk and the baby's screaming, and you're like, I guess I won't warm it. I'll just feed it and see how it
Yeah.
goes.
Yeah, no,
So
that's true.
babies are getting cold milk at home, right? So
They are getting cold milk. I mean, even yeah, I agree. I agree. All right. All right. We have a few more articles to go through. I really wanted to talk a little bit about. I have two more articles. I'm gonna want to give us a little bit of a break. I wanted to talk a little bit about something that is um, a subject we don't talk about often, which is it's a paper that I found in Journal of Perinatology. It's called "Impact of Teleneonatology on Time to Goal Temperature in Outborn Neonates with Hypoxic Ischemic Encephalopathy Requiring Hypothermia." First author is Mark Caxor, and last author Jennifer Feng, who is on our lineup for the Delphi conference. But it is a topic that we're very interested in. And this group out of the Mayo Clinic in Rochester basically was examining how telemedicine technology can improve outcomes for basically one of the most time sensitive interventions in neonatology, therapeutic hypothermia for HIE. So, HIE, the background is interesting. We know most of it. It remains a leading cause of neonatal morbidity and mortality worldwide. Therapeutic hypothermia is pretty much the only intervention that is available at this time, and it relies on prompt initiation to optimize neuroprotective effect. And this can be logistically challenging for neonates that are born at non-tertiary centers and that require transport to regional centers. These are like what we would call the outborn population. Now, outborn neonates that require hypothermia for HIE, they've been reported to have higher rates of death, higher rates of seizure necessitating treatment. Oh my God. Gastrostomy tube placement compared to neonates born at a hospital with a NICU and the ability to actually deliver therapeutic hypothermia. And so this highlights the critical importance of optimizing the care pathway for these vulnerable infants. Now, in terms of teleneonatology, real-time audio-video telemedicine consultation with a neonatologist provided to surrounding community hospital is a potential means to accelerate this process by offering expert assessment and recommendations within minutes after birth. Teleneonatology has been shown to increase the quality of high-risk newborn resuscitation. It's been shown in previous retrospective cohort study to demonstrating that perinatal asphyxia or encephalopathy was the admission diagnosis for 15% of neonates who underwent consultation. And while utilizing telemedicine to assess neonatal encephalopathy, it has been shown to be at the same time feasible, but it is unknown whether it could improve therapeutic hypothermia process in early health outcomes in these neonates. So the objective of the study was to assess whether teleneonatology can be associated with earlier achievement of goal temperature in outborn neonates with HIE that underwent cooling. And the secondary objective was to determine whether teleneonatology was associated with a reduced early neurologic morbidity or in-hospital mortality. This was a retrospective observational study of neonates who were born at community hospital and transferred to the Mayo Clinic for therapeutic hypothermia to treat HIE between 2013 and 2022. They have a bit of a description that the Mayo Clinic basically has a 24-bed level 3 NICU and a 34-bed level 4 NICU, and basically approximately like 800 admissions a year. Um, and all the neonates that we're going to talk about today are neonates that underwent cooling at the level 4. Now, the decisions regarding the initiation of therapeutic hypothermia for HIE were made based on the criteria from the NICHD and the Neonatal Research Network trial on cooling. The exposure of interest in the study was the consultation via teleneonatology, which is a video telemedicine service that's available to outlying hospitals 24 hours a day, 7 days a week, and that allows neonatologists to remotely assess and advise on the management of neonates at community hospitals. Now, during the study period, subjects were admitted from 19 different community hospitals. 12 of the facilities participated in Mayo Clinic's teleneonatology program for at least some portion of the study period, while the remaining 7 did not. In hospitals participating in the teleneonatology program, the referring physician could choose between initiating a phone or a teleneonatology consultation. Physicians at sites without teleneonatology initiated a phone consultation with the neonatologist. Now, during the phone consultation, which served as the control group in that case, um, the transport team could be dispatched by the neonatologist as soon as it was identified that the infant required a higher level of care. So you didn't have to like hang up, call the transfer center, get the face sheet faxed over, and do a formal sign out. Like while you were on the phone, it's almost, it didn't say this, but it almost feels like they could press a button and activate transport. If they did not use the teleneonatology consult, a separate phone call by the referring physician was needed to activate the transport team. The primary outcome of the study was time from birth to the achievement of core temperature between 33 and 34 degrees Celsius, obviously being the goal for therapeutic hypothermia. Secondary composite outcome were early neurologic morbidity or mortality, including the presence of any of the following: electrographic seizures, evidence of significant brain injury on MRI, and or death prior to NICU discharge or transfer. So let's get into the results. So 77 neonates met eligibility criteria and were included in the study. Of these, 42, 55% of the cohort were in the teleneonatology group. 35 others, 45% of the cohort, were in the control group. The baseline characteristics were generally comparable between the teleneonatology and the control groups, with the exception of race, where there was a difference in distribution observed, where there was 71% of the patients who were white in the teleneonatology group versus 83% in the control group. Now, in terms of advanced airway placement in the delivery room, it occurred more often in the teleneonatology group at 31% compared to only 20% in the control. Whereas both groups had similar proportions that received the chest compression at 26% in both groups, and epinephrine was used in 7% versus 6%. So I think that already is quite interesting, the ability to more readily rely on advanced airways. The median time between the transport team being dispatched from the Mayo Clinic and arrival at the birth hospital was comparable between the groups, surprisingly: 50 minutes in the teleneonatology group versus 55 minutes in the control group. So I would have expected that to be a little bit more different. In the teleneonatology group, the median time from birth to initiation of the telemedicine consult was 13 minutes, and the mean consult duration was about 56 minutes. Now, for the primary outcomes, neonates in the teleneonatology group achieved goal temperature in a median of 3.4 hours compared to 4.6 hours in the control group, representing a mean ratio of 0.75. This difference remains statistically significant when adjusting for patient acuity using the blood gas pH, with an adjusted mean ratio of 0.76. A few more results. The study also conducted a sophisticated causal inference analysis using directed graphs, a Sillic graph, to understand the mechanism behind this improvement, and they identified 2 key mediating factors. The time from birth to activation of the transport team was reduced in the teleneonatology group, occurring at a median of 23 minutes compared to 61 minutes in the control group. So you see, we're all struggling with the same thing. We activate it, but it takes some time to get there. Additionally, infants in the teleneonatology group had significantly greater odds of having passive cooling initiated prior to arrival of the transport team, 57% versus 14% in the control group. Now, in terms of safety concerns about overcooling, 7% of the infants in the teleneonatology group were overcooled compared to 6% in the control group that were below that target temperature on transport team arrival. So even the passive cooling, it really did not lead to a problematic overcooling. And for secondary outcome, there was no detectable difference in the composite outcome of early neurologic morbidity or mortality between the groups, 57% versus 49%. The conclusion are that teleneonatology does reduce the time to goal temperature among outborn infants treated with cooling, and that their findings highlights the potential for teleneonatology in improving the timely delivery of care to this particular vulnerable population. I think that we may say, oh, what's the difference? 3.4 versus 4.6. But I want to highlight that this is a topic that is actively being studied by
That's
a
more
lot
than
of
an hour.
that's more than an hour,
Yeah,
but it still remains within the 6 hour window. And I think that we may be tempted to think, especially as young trainees, that like, oh, as long as it's done within the first 6 hours, it's okay. But there's more and more data that is showing that
for
maybe
sure.
earlier initiation by 1 hour at a time may have incremental benefits. And so this is something that I was talking to a friend of mine about regarding like, could teleneonatology be a little bit ahead of the curve when it comes to highlighting something that will be beneficial? Maybe we don't have the data yet to show that cooling at 1 hour versus 4 hours is a massive difference, but yet we're able to do it already because if you activate a consult system using telehealth, you might be able to achieve that goal. I thought this was a very interesting, I think it's a very interesting paper. One of the reasons we're highlighting this topic at Delphi as well is because this is coming and you're reading this and you're like, oh my God, like if I take a job somewhere, I might be on the hook for providing teleneonatology services to outlying hospitals. I don't know about you, Daphna. I've never done this before. It's
I mean, we did extensively at the University of Florida, and actually, I mean, Mike Weiss has been doing tele-SARNets for some time, and actually, I mean, I think specifically for this indication, I
right.
think it's really interesting. You know, we talk about this all the time in our state collaborative for referral centers, and many of our listeners are at referral centers. If the difference between phone and tele in this situation is the babies change over time, right? So within the hour to 2 hours to sometimes 4 hours that you get a baby, they may look different than when the other professional sent the baby.
Mhm.
So, I mean, being able to evaluate that infant by video, at that time, I think is very valuable because we talk about this all the time. What if you get a baby who now looks pretty good, but didn't look pretty good, or looked pretty good and now doesn't look pretty good? You know, how does that change what you might do for that infant? So,
For sure,
yeah.
for sure. And I think that like I was saying earlier, like for me, I know that the tech is there. Like you
Yeah.
can get very high
Easy. Yeah.
resolutions video, and it's not like you're gonna be on it's not gonna be like FaceTiming your grandmother across the globe. Like, I mean, sometimes it feels like, oh my God, like, am I really gonna have to make a medical decision based on like a
Yeah.
very sort of pixelated, shoddy type of image that's shaking? No, like the devices are there, they're stable. And I think it's important for us to start learning about them because tomorrow your hospital might say, hey, we're gonna provide that service to our outlying neighboring hospitals. And then, yeah, so I think it's gonna be an interesting topic and it's definitely an interesting study to say the least.
You had one more you wanted to run through?
Let's do it. I'm not really going to run through, but I'm going to do it. It's an important paper. Um, this is a paper that was published in the Journal of Pediatrics. It's called Norepinephrine versus Dopamine for Septic Shock in Neonates, a randomized control trial.
Love it.
I feel like we're bearing the lead. It was an important paper, and we're reviewing it at the end of the episode, but it will be available as a Journal Club short, so that's okay. Um, the question is always the same. Which vasopressor do we use as a first-line agent for septic shock in neonates? Sepsis is an important cause of admission to the NICU. We've talked about sepsis a lot today already, just on this journal club alone. And it's a significant contributor to neonatal morbidity, mortality, especially in low and middle-income countries. Septic shock in particular has been associated with a high case fatality rate of about 40 to 80%. Now, the management of septic shock involves timely initiation of fluids and vasoactive support, along with other supportive measures and antibiotics. However, there's a lack of well-defined management protocol for fluid refractory septic shock in neonates, and the plausible reasons include unclear definition of hypotension in neonates. We always come back to that question. Complex pathophysiologic process ensuing cardiovascular compromise, and a lack of robust evidence. Now, the recently published pediatric and adult survival sepsis guidelines prefer the use of norepinephrine over dopamine as the first-line vasoactive agent for the management of septic shock based on evidence which favors norepinephrine in terms of reduced all-cause mortality and better cardiovascular profile in adults. However, several pharmacological factors support the use of norepinephrine over dopamine, specifically in neonates. And there are several reasons. The first one being that the pathophysiology of septic shock involving low systemic vascular resistance can be addressed adequately by a potent alpha 1 agonist, such as norepi. Second, dopamine exerts its action through the release of norepinephrine from sympathetic nerve endings, and this might become a limiting factor in sick neonates with limited reserves. So if you're providing it yourself via medication, then you might be overcoming that. Moreover, um, Moreover, the metabolism and clearance of dopamine is dependent upon postmenstrual age and may cause drug accumulation in unstable preterm neonates. Lastly, norepi may reduce pulmonary vascular resistance and improve pulmonary hypertension, which is a common association in neonatal sepsis. So the authors conducted this study to determine the efficacy and the safety of norepinephrine compared to dopamine as an initial vasoactive agent. This was a double-blind, parallel group randomized control trial conducted at a tertiary center in northern India for over a period of 18 months. All neonates, both term and preterm, with fluid refractory septic shock admitted to the NICU were included in the study. Each neonate was enrolled only once. Term neonates were enrolled until day 28 of life, and preterm neonates until 40 weeks postmenstrual age. The definition of shock was adapted from the American College of Critical Care Medicine guidelines as the presence of hypotension, defined by systolic blood pressure, diastolic blood pressure, or mean blood pressure at or below the third centile for gestational age, along with any two of the following criteria: a decreased urine output of less than 0.5 ml per kilo per hour over the past 12 hours, cap refill of 4 seconds or greater, a lactate greater than 5, metabolic acidosis with a basic CES greater than 5, or superior vena cava flow less than 40 ml per kilo per minute. Hypotension was assessed via invasive blood pressure monitoring through an umbilical peripheral arterial line. Fluid refractoriness was defined by the failure of reversal of shock after receipt of one or more fluid boluses of 10 ml per kilo over 10 minutes, guided by the assessment of fluid status. The diagnosis of sepsis was based on either a positive blood culture or a positive sepsis screen or a compatible clinical course as judged by the treating physician having received antibiotics for at least 5 days. They excluded babies with congenital anomalies, moderate to severe HIE in the first 72 hours of life, neonates already on inotropes, and shock in the first 24 hours of surgery, and failure to obtain consent. The primary outcome of the study was the incidence of shock reversal at 30 minutes after the initiation of the vasopressor support. Shock reversal was defined again using the American College of Critical Care Medicine guidelines as the correction of hypotension, along with any two clinical endpoints: cap refill of 2 seconds or less, normal pulses with no difference in quality between peripheral and central pulses, and warm extremities. Secondary outcomes included changes in cerebral tissue oxygenation, need for further escalation of vasoactive treatment, time to reversal of shock, requirement of steroids, incidence of hyperglycemia, defined at a blood sugar level of 180 or higher, tachyarrhythmia, sinus tachycardia, need and duration of respiratory support, and changes in acid-base parameters at baseline 6 hours, 24 hours after the diagnosis of shock, including pH, bicarb, basic CES, and lactate. The participants were basically randomly assigned to either receive norepi or dopamine in a 1-to-1 ratio, stratified to less than 35 weeks and 35 weeks of or greater subgroups, and all study investigators and healthcare personnel except the study nurse were blinded to the intervention. The dose of norepi that they were using was 1.5 ml per kilo of norepi at 1 milligram per ml, was diluted in 50 ml of 5% dextrose, and was initiated at 0.4 ml an hour, which equals to 0.2 microgram per kilo per minute. The dopamine group basically was started at 10 micrograms per kilo per minute. Shock reversal was assessed at 15 and 30 minutes of initiation of vasopressor support. The neonates who did not achieve therapeutic endpoints were started on other vasopressor drugs as per the decision of the clinical team. Crossover to the alternate arm was not permitted, except in infants refractory to multiple vasoactive agents. So Very interesting study. Let's get into the results. 18 neonates were eligible and randomized into norepi, 41 babies, dopamine, 39 babies. The majority of neonates had late onset neonatal sepsis, 60% in the norepi group, 64% in the dopamine group. The median age at enrollment was 4 days, which was comparable between the two groups. And among the enrolled neonates, 49% had culture positive sepsis. So still, like a lot of them with sort of this culture negative sepsis. The most common isolate were gram-negative organism, and the mean gestational age was 33.2 weeks in the norepi group and 33.2 weeks in the dopamine group. No difference there. In terms of the primary outcome, the proportion of neonates attaining reversal of shock by 30 minutes of initiation of vasoactive support was similar between the group, 31.7% in the norepi group, 46% in the dopamine group, with a p-value of 0.19. The requirement of additional vasoactive agents and steroids was similar in the two groups. There was no difference in the proportion of neonates attaining shock reversal at any time point between the norepi and dopamine group, 48.8% versus 53.9%. The time to shock reversal was also similar, 1 hour in the norepi group, 1 hour in the dopamine group. While the incidence of hyperglycemia was similar in the two groups, neonates enrolled in the dopamine group had a higher incidence of tachycardia, 2.4% in the norepi group versus 15.4% in the dopamine group. The proportions of neonates with IVH grade 3 to 4, ROP, NEC, were similar between the two groups. There was also no difference in all-cause mortality between the two groups. When they were looking at some of these more specific endpoints, cerebral tissue oxygenation saturation were similar at 30 minutes and at 6 hours post-initiation of therapy, but they were significantly lower at 24 hours in the dopamine group. It's a very interesting finding. And in addition, neonates in the dopamine group were significantly more acidotic at 24 hours following initiation of vasoactive support, with a pH of 7.27 in the norepi group compared to 7.19 in the dopamine group, with a p-value of 0.04. The blood lactate levels were comparable between the group. In the subgroup analysis, looking at the different gestational age, they found no significant difference in the results in the less than 35-week subgroup. The dopamine group had significantly higher incidence of hyperglycemia compared to the group that was a little bit more mature. I think that what's important here to note is that when we're looking at the number of babies, the number of infants less than 35 weeks was like 25 and 24, and above 35 weeks, 16 and 15. So actually, most of them were in that premature group. The mean gestational age, though, was 33 weeks, as we mentioned. So they were not that premature either. The conclusion of the article is that norepi and dopamine have comparable efficacy in neonates with fluid refractory septic shock. However, the dopamine group had higher incidence of tachycardia, lower pH, and lower cerebral tissue oxygenation at 24 hours following the initiation of therapy. There is a need for larger multi-center trials evaluating the efficacy of different vasoactive agent in neonates with septic shock, emphasizing the long-term neurodevelopmental consequences of those interventions. A very interesting paper for a very interesting population.
What do you think?
I think that there's more and more data that norepinephrine has a place in our arsenal of vasopressors. I think we use it not as often as we should.
Yeah.
And I think that when specifically the biggest problem, I believe, in our field is that we have a very difficult time in identifying the different types of shock. I think we're all very familiar with what the different types of shock look like. But in the adult world, it is a little bit more clear-cut what you're dealing with. Are you dealing with hypovolemic shock? Are you dealing with septic shock, cardiogenic shock? In neonates, it sometimes feels like you're dealing with all of them at once.
Yeah.
And it's not exactly clear then what should we go with. And so sometimes, yeah, the reflex of going dopamine first is because I'm not exactly sure what this is about. Is this baby, right? A baby that is having a bad IVH and is losing and is pulling some blood in the brain. Is that hypovolemic shock? Like, is that enough blood that's being lost on a 600-gram baby to actually constitute hypovolemia? Or is the baby having an IVH because they are septic?
Yeah.
And then this is septic shock? I think that is where our field has always sort of had difficulties, not to the fault of the clinicians, but to the fault of the pathophysiology of our babies that is so sort of interlocked and complex with so many things happening at once. I think that if you have fairly certain perspective that this is probably a fluid refractory septic shock, consider norepi, and you would be supported by some pretty robust evidence here.
Uh-huh. I had 2 papers I wanted to highlight, but we are, like, way over time already. What do you
Are you
think?
going to save them for next time,
I mean, I
or you
guess
want
I
to
can
do a
save
quick
them for
one,
next time.
or you want to
How
do
about I
one?
how about I just do 1?
Let's do it.
Okay. All right. I it's a meta-analysis, so I am not gonna go over the whole thing, but I will review the findings in the abstract so that people can go take a look. And it's entitled All-Cause Mortality and Infection-Related Outcomes of Hospital-Initiated Kangaroo Care versus Conventional Neonatal Care for Low Birth Weight Infants, a Systemic Review and Meta-Analysis. Um, and the lead author, Chiara Minotti, senior author, Julia Bielicki. And this is in the Lancet Child and Adolescent Health, actually. So they wanted to evaluate specifically how kangaroo care might impact infection concerns for low birth weight infants. And again, there's a lot of data. I'm not going to belabor the point, but I do think they have a really nice background there. A reminder that most guidelines recommend, 1 hour of uninterrupted kangaroo care a day. And the WHO actually recommends targeted durations of 8 to 24 hours of kangaroo care per day when possible. So most of us, especially in the States, are kind of missing the mark on that. They eventually, in their data set, included 29 studies. I will highlight this is an argument everybody says, mainly from lower middle income countries. There are 2 papers from the US and 1 from the UK included. Some of the papers are quite old, 1 to 2 decades old, but they were included. And most of the studies were considered to be moderate to high quality. So I will just review some of these findings. 86% of the studies reported all-cause mortality in the meta-analysis. And again, hospital initiated. So all of these were done in a healthcare facility. I think some people hear low to middle income countries and they think, oh, we're just doing it anywhere willy-nilly. But these were in hospitals. So hospital-initiated kangaroo care reduced all-cause mortality, a pooled odds ratio of 0.77, felt to be high-quality evidence. 17 or 60% of the trials reported sepsis as an outcome, and the pooled results showed that kangaroo care reduced the odds of sepsis, an odds ratio of 0.55, moderate quality evidence. Similarly, among the 11 or 38% of studies reported invasive infection, the pooled results showed that kangaroo care reduced the odds of invasive infection, an odds ratio of 0.49, moderate quality evidence. Kangaroo care was associated with a significant reduction in the odds of sepsis-related or invasive infection-related mortality with an odds ratio of 0.63. High-quality evidence was also associated with a reduction in hypothermia, an odds ratio of 0.28, moderate quality of evidence, and a reduction in apnea, 0.46, moderate quality evidence. And the meta-regression showed this between study heterogeneity was most likely due to a variation in the level of kangaroo care offered as part of the conventional neonatal care. So some people as conventional care had a lot of kangaroo care, and that was part of what was found. So I think the argument some people might say about this is, yeah, it's reducing infection in low to middle income countries. Um, I think potentially can do the same thing for us if we were as invested as some of these other countries were in prolonged kangaroo care. So I just wanted to highlight that paper before we log off today.
Yeah, that's a very interesting. That's a very interesting point where the intervention has the proof is in the pudding. It's just like we're still not implementing as
Yeah.
best as we can, and it's also like and resources are not the issue.
Right.
You're not missing a machine that your hospital cannot afford.
Yeah.
That's what's so frustrating. I
Yeah, I mean,
think.
I think for us, the resource is the parent, right? So
Yeah,
our system makes it so that we can't afford to bring parents to the bedside. But if you have a parent at bedside, then they should be given the option to do kangaroo care.
yeah, and pretty interesting data on the infections as well. Anyway,
Yeah.
thank you, Daphna, for running through this and for another episode of Journal Club. We will see you guys later this week with more incubator content. And again, feel free to leave a review or a 5-star review on Apple Podcasts. This helps us a lot.
Mhm.
You guys have a good rest of your day.
Bye, everyone.